I want you to keep this in mind again. Okay, the signal can be a micro damage, can be mechanical stress, okay, can be hormones, or can be cytokines. They activate the bone, and the remodeling happens at the sites the bone is activated. Okay, I want you to keep mechanical stress in mind. Okay, it will all add up at the end. Okay, so once there is stress, then osteoclasts come and destroy, okay, the cells or the bone matrix where the stress came, okay? And then there's an activation and there's a reversal, okay? The osteoclasts become apoptotic and they die, okay? And the osteoblast precursors come to the side and the bone is formed, the bone matrix is formed, okay? And bone is restored, okay? And when you know that when there's a remodeling, then the remodeling happens according to the stress, right? Isn't it? If your stress is demanding a thicker bone, then you get a thicker bone, isn't it? Right? So what does estrogen do? It's a complicated thing, okay? What I want us to go home with is that estrogen basically helps in the homeostasis of the bone, okay? It helps to maintain bone growth, okay? So there, for the osteoblasts, okay, it increases the bone matrix synthesis, it increases mineralization of the bone, okay? And it decreases the osteoclasts, okay? It decreases the destroyal or the destroying of the bone. It keeps them in check, okay? It basically keeps them in check. The osteoclasts are supposed to destroy, but if estrogen is there, it says enough, stop there, okay? We need to now start regenerating, okay? So, normal estrogen levels, you'll get a balanced bone remodeling, you have a nice thick cortical and trabecular bone, and you have a healthy and strong bone. When you have estrogen deficiency, you have increased bone turnover. And this is what happens in menopause, okay? The osteoclasts are now have a free rein. So they come in and start destroying, okay? There's nobody to stop them, right? The red light has gone, okay? So then you get bone loss and subsequently osteoporosis. You start by getting a fragile trabecular architecture, and then subsequently you get cortical bone loss as well, and you get fractures, okay? So how does osteoporosis impact us? This is very, very important. 1 in every 2 women. So like, if we draw a line, half of us are going to get a fracture in our lifetime, okay? 1 in every 2 women and up to 1 in every 4 men will break a bone in their lifetime due to osteoporosis. It might not be our data. This is more for Caucasians. But we are heading there. We are heading there. That is the lifestyle we are now emulating, isn't it? We are emulating them, isn't it? That's the lifestyle we are adapting. It's what we are practicing, isn't it? Right? So we are heading there very soon. Okay? So again, this is just how the bone mass density drops as soon as menopause sets in. Okay? And I just want to bring to your attention here, the figures are a bit, they're not so clear, but there's a comparison between men and women. So for myocardial infarction, men are more prone. So men are more. Lung cancer, men are more prone. Prostate cancer, of course. Breast cancer, of course, women are more prone to getting breast cancer. But for hip fracture, it's the only other place apart from breast cancer. I mean, if you talk about breast cancer, it's known to be a women's cancer, isn't it, right? But hip fracture, ideally it should be equal, isn't it? We all have hips, isn't it? Men have hips and women have hips, right? And they're all active. But the rate of this rate of incidence is much more higher in women. Okay, so impact of osteoporosis. So this is just a graph to show us, okay, the mortality, okay, the death in 1 year within getting that fracture. And look at the data. If somebody gets a hip or a femur fracture, there's a 20 to 30% chance of death within the first year. And these are osteoporotic fractures we are talking about. So we are talking about these fractures in women at around 60, 65 years of age, right? A woman from then on, a woman who went into menopause at about 50 to 52 years. Okay? Right? So there's a 20 to 30% chance of death within 1 year. Okay? Because if you're osteoporotic, you probably have not got good good skeletal muscle as well, right? Your muscles are also wasted, right? You probably have issues in joint mobility as well. True or false? Right? And associated with that, you probably have a BMI that's quite high, right? True or false? Right? All these things come together. And that's why bone health defines you. Okay? It defines you as how you will age. Okay? So identifying perimenopausal women at high risk for osteoporosis. This is for us in our clinics, right? Okay? No clearing and forwarding. Let's think of osteoporosis. Okay? Advanced age. So most women who go into menopause at about 50 to 52 and are not doing anything to promote bone health, right? They will be getting osteoporotic by about 65 years of age. Okay? Right? Body weight. Now here is where, yeah, I can see people understand. Here is where if your BMI is higher, you're better off, isn't it? You have stronger bones. I'll explain to you why. Yes, you have stronger bones if your BMI is higher. If your BMI is low, then your bones are weaker. And I'll explain why. Right? It is not the impact, it's not that your fat is saving you from the fall, right? Your fat is not acting as a buffer. Okay? I'll explain why. Keep it in mind. History of fractures. So if you've had previous history of fractures, because the bone, of course, once broken, you know, it repairs, but it's probably never the same, right? Family history of osteoporosis, your medical history. Are we diabetic? Do we have inflammatory bowel disease, depression, some connective and autoimmune diseases, okay? Because they affect the bone mass. History of prolonged use of certain pharmaceuticals, social history, chronic tobacco and alcohol use, and lack of dietary calcium. Okay, so in other countries, not in Kenya. In Mombasa, we don't even have DEXA, do we? We don't. We don't have DEXA. We don't have DEXA in any of our major hospitals. Okay? So let's start by identifying the risk factors. Okay? So there's an online fracture assessment, risk assessment tool that we can use, that's used in the States, right? And it kind of gets all your history, and it estimates the 10-year risk fracture risk, and that allows you, that allows your physician or to help you or to guide you as to how you will move next. Okay? It's country specific and race, ethnicity specific calculations here. See? You actually, there's a drop down and you actually pick which country you are from, because that will, will define your nutrition, will, according to your economic level, all that, right? So the goal is to risk stratify treatment naive patients, okay? So frailty is not captured, I'll explain what that is, and diabetes is not included, that's the only setback. Okay? So Frex estimates empirically lowered 50 to 60% osteoporotic rates in the US for non-white women. Okay, then there's this osteoporosis self-assessment tool. It's also available online. It's mostly used in Europe, but it's not very specific. The specific rates, there were lots of false positives, and specificity ranged from only 34 to 40%. So it's ish. They're still, it's still getting better. It's still being refined. Okay. So bone mineral density measurement that estimates bone strength is the baseline for our assessment. So there's DEXA, which is the most widely used, which is not available in Mombasa. Okay? They're using CT scan assessment or densitometry of the bones. I've seen some of the oncologists around use that. But it's not very consistent. There are no clear guidelines. And it's not what you should ideally be doing. Okay? So these are all the other methods. Vertebral fracture assessment with densitometer, peripheral dual energy X-ray absorptiometry, CT-based absorptiometry, quantitative ultrasound densitometry. Okay, so DEXA. So DEXA uses a T value, a T score, okay, to compare your bone density with that of a healthy young adult. So if you're 55 and you're being done DEXA, of course your bone will not be like a 20-year, okay? Because 20-year is the standard, because that is when you have your peak bone mass, okay? The peak bone mass, especially for girls, is at 20 years, okay? So normal bone is about, you can give it about 1 standard deviation, okay? The T value about 1 standard deviation below the normal, that is -1. Osteopenia is when you have a T value of between 1 to 2.5, or you call it below the standard deviation, or you say -1 to -2.5, okay? And the World Health Organization defines osteoporosis as a BMD greater than 2.5 standard deviations below the average, or -2.5. Are we together on that? Okay, severe osteoporosis is BMD greater than 2.5, greater than 2.5 standard deviations below average, and 1 or more fragility fractures. So the International Society of Clinical Densitometry guidelines recommend the use of Z-score. So Z-score is like the T-score, but now it is used for the same sex and for the same age. So it makes it a little bit more realistic, okay? It is more realistic. You're not being compared to a 20-year-old, right? You're being compared to an average healthier 50-year-old, or an average healthy 50-year-old, okay? So it is a Z-score of more than -2 will be considered clinically significant. So now, see, it has been brought down, right? The boundary, or the threshold has been brought down, because this is somebody who is your age, right, and who is your sex, okay? So osteoporosis can also be diagnosed if there's a fragility fracture. Okay, and fragility fractures are the ones that happen without a lot of impact, or spontaneously, or they happen spontaneously. Like somebody is just standing, right? And then they just fall, right? Have you heard of all these people? No, I did not slip. I didn't trip or anything, but they just fell. You have heard of this, right? These are osteoporotic fractures, and they mostly affect neck or femur, right? Femur neck, right? You need a hip replacement. Okay, and they tend to happen in certain places in the aging body. The spine, right? And it comes with cord compression, or cord compression develops before that, right? You see people developing a hunch or reduction in height. Have you seen that? Right? Your mother was taller than you, now she's shorter than you. Right? Okay? So they mostly happen in these places. So fragility, fractures are the ones that happen without any tension. Okay? And that's why being fat it's not the muscle or your fat that protects you from the impact. The bone breaks before you fall. Okay? So these are the highest fracture risks in osteoporosis. Okay, the hip. Okay. The hip, the wrist, okay? And the lumbar spine. Okay, so you recommend meds when there's a prior fragility fracture. Okay, there's a DEXA T-score of less than -2.5, and the FRAX calculator gives you a 10-year major risk of more than 20%. So meds are not usually provided for osteopenia, and this is what I want you to take home. Do you want to get to osteoporosis? No, isn't it? Right? Do we want to get to osteoporosis? No. Right? Do we want to get to osteopenia? We don't want to. Right? Okay, sometime we will, right? But we have to try and maintain our bone mass. Okay? This is something that you should go home from. You should go home with from here. Okay? So now, before launching into medical therapy, you need to rule out secondary osteoporosis. Secondary, what we are talking about, what we were talking about, osteoporosis due to aging or menopause, is called primary osteoporosis. Secondary osteoporosis is not the impact, again, it's not due to an accident or trauma or something. Secondary osteoporosis is osteoporosis due to your medical history, right? Or medications that you have been taking, or the kind of lifestyle that you have been leading. Okay? Okay, I really wanted to talk about this. Drug-induced, because we are medics, and I hope Dr. Mariam will allow me some extra time. We spent a lot of time with Simon Singh. Okay? So it is a significant health problem. And as physicians, okay, as medics, we should be able to pay attention to the drugs we are prescribing and the effects they are going to have on somebody's bones. And sometimes we don't only prescribe one, right? Those on anticonvulsants, sometimes they are on 2 anticonvulsants and both of them are causing osteopenia. Okay? And some of them are, how many have you seen? They are on glucocorticoids, they are on PPIs because they are on glucocorticoids, right? And they are on some sort of cytotoxics as well, right? And how many of those do we support with advice, with medications to support their bones? We kind of tend to overlook this, right? Okay, so this is something I want to bring to your attention. Okay, aromatase inhibitors, medroxyprogesterone. Wangapi tunapeana wasichana depo below 20 years? They're not even developing their peak bone mass, right? Your peak bone mass is at 20 years. Somebody comes with AUP in their teenage years, you put them on medroxyprogesterone continuously, 3 months, anarudi baada ya miezi sita, another 3 months. You combine, you put them on medroxyprogesterone. Medroxyprogesterone is known to give you bone loss. Okay? Therefore, 6 years continuously. Okay? So we need to be looking into these things. Okay? So prevention of bone loss and management of osteopenia and osteoporosis, it has got one big component where pharmaceuticals are involved, and the other major component is lifestyle interventions. And that is what I want us to take home. This thing about self-style should include this. Sawa? Okay? So, I'll just go. So, on one hand, in the medical treatment is anti-resorptives. These are the ones that suppress your bone from being destroyed. Okay? On the other hand are anabolics. Anabolics promote bone growth. And the third one is menopausal hormone therapy. It is not recommended as a treatment, though the hormone enthusiasts are really promoting for it to be recognized by FDA as a treatment for osteoporosis. However, presently the recommendation is for prevention. Okay? So bisphosphonates are the recommended first line. I'll not go through everything because I don't think it actually meets the criteria of our gathering, right? It's a bit too complex, right? For anybody who wants to know more, you can come and we talk, or I can share my presentation with you. Okay? So bisphosphonates are our first line. They inhibit bone resorption and they're known, they're quite effective. Okay? They're oral tablets and they're IVs. Okay? The oral tablets are a little complicated to take. Okay? Because they cause gastroesophageal irritation. So when you take the tablets, you have to have a full glass of water and sit upright for the next 40 to 60 minutes, right? Or even more. Otherwise, you develop, gastroesophageal irritation and hyperacidity and all that. Okay? The IV is better, right? Because you take one IV for 3 years. Okay? They have a good bone maintenance. Means you can go off the medication for some time and your bone will not. You'll not get a lot of bone loss, okay? Then there's the selective, the SERMs, raloxifene, there's tibolone, okay? They also help the bone, okay? Then there is the monoclonal antibody. It's also an anti-resorptive agent, okay? However, it has got a lot of bone loss immediately you stop it. So there's no, what you have to do is you have to put sequential treatment. If you've put a patient on denosumab, then you have to transit the patient to bisphosphonate after that. Okay? So anabolic drugs for osteoporosis are the best, of course, because they actually help to build your bone, right? So in very severe cases, these are more expensive. They come in terms of subcutaneous injections. Okay, on a daily basis. They come like, the insulin and the fertilization drugs which you can do for yourself, okay? Treatment is generally limited to 2 years, so you build the bone up and then you proceed with bisphosphonates to give the anti-resorptive effect. So there's one which is really under investigation, Evenity. It prevents resorption and it's also an anabolic. But it has had a few cardiovascular events and that's why, it's used with a lot of caution. So, achieving bone health. Okay? This is what I want us to go home with. And I really want us to go home with this because this is what we could be doing for ourselves and our families and also our patients, okay? So our goal is to maintain bone mineral density and reduce fractures. Maintaining bone mineral density, preventing bone loss and reversing osteopenia is what bone health is about, okay? And this is, you'll not get a result over one day, okay? This, when you're planning or when you are when you're aiming to have good bones up to the age of 70, okay, then this is something, these practices are something that you need to be consistent with, okay? Consistency is the name of the game, okay? So number one, we need to change our mindset, mobilization. This mindset, nishafika 50, life imeisha, sindio? 50 is the new 30, right or wrong? Huh? Yeah, 50 is the new 30. Sindio? Okay? So, but mindset change, right? Mobilization, learn to move, learn to make progressive changes for your health. Okay? Because this is your quality. It's the quality of life you lead. Okay? You can die at 90, but what is the quality of life you are leading? Okay? So, however old you are, you can still retrain, change habits, and make a difference. Okay? Number 2, MHT, that is menopausal hormone therapy. Please, I have proof from WHI, but let's discard the notions from a study that came 25 years ago. Okay? When I was doing my master's, we did not even touch menopause and menopausal hormone therapy because of the WHI study, right? Which has been proved time and time again wrong, okay, from the other studies and RCTs that have come up. Stop thinking that MHT will cause you cancer, okay? Menopausal hormone therapy, don't correlate it with breast cancer, don't correlate it with ovarian cancer, don't correlate it, okay? We know how to go about it, and we also assess risks, okay? There's a lot of study on it. Dr. Mariam will talk behind. Okay? So, menopausal hormone therapy is an anti-disruptive, okay? It is a bone builder. So you're getting everything together in one, and you're getting it as a prevention, even before your bone loss starts, okay? It prevents sarcopenia. What is sarcopenia? What is sarcopenia? Where is Dr. Zainab Ginangop? Ashaenda? Students, registrars, sarcopenia. We don't know sarcopenia. Hariya. I'm talking Greek here. Sarcopenia is loss of muscle mass. Sawa. Okay, it's loss of muscle mass. Sarcopenia. As we age, we lose muscle mass, isn't it? So, menopausal hormone therapy, it doesn't only help your bones, it helps your muscle mass as well. It helps in joint mobility and flexibility. It helps to reduce cardiometabolic effects of estrogen deficiency that indirectly affect bone strength, isn't it? By cardiometabolic effects, I mean insulin resistance and diabetes, right? Cardiac diseases, isn't it? Right? So they will affect, and the medications will affect your bone, your BMP, okay? Right? Your bone mass. But not only that, if your BMI is high, right, you're not going to do anything, right? You're not going to walk, you're not going to exercise, you're not going to do anything, isn't it? Right? It helps reduce neurological and psychological effects of low estrogen, and thus debilitating old age conditions which ultimately lead to osteoporosis. Okay? So this is what happens to your bones, right? And menopausal hormone therapy helps to prevent this decline. Okay? So this is from the famous WHI study, right? The reds are the side effects, okay, which I'm not going to go into the details, but this study was not the best, okay? So even at that point, with CEE plus MPA, there's a positive effect for fractures, okay? With CEE alone, conjugated equine estrogen, again there was a positive effect on all fractures. So estrogen has a positive effect on fractures, and that's why postmenopausal, the decline of bone health is rapid. Okay? Again, positive effects from MHT on fractures, on preventing fractures. Okay? So we say the first is your mindset. Number 2, we will reel these out at the end. Menopausal hormone therapy, because this is what we need to go home with, seriously speaking. Okay? Number 3, physical activity. Okay? Mechanical load, impact and resistance training. So this was what the jumping was about. Okay? So this is what happens when you have a mechanical load. Okay? When you carry weights, right? When you jump about. Okay? In your bone matrix, there's a canal called canal Varna, okay? That has got a fluid in it, and that passes a biochemical signal to the bone, okay? And the bone starts remodeling, okay? And you get heavier bones, your bone mass density increases. Okay? So it increases, it gives you bone building, right? And this is what the exercise would look like. So walking, they say the study findings say that jumping from an 8-inch step can produce 4 times body weight load. Okay? The impact. And then it stimulates the osteogenesis pathway. Okay? So yes, we are walking, but walking will only give you 1.5 of the body load. Okay? And running will give you 2.5. That's why they say don't run. Do other things, right? Do resistance exercises, do impact, okay, weightlifting, okay? So that is where HIIT comes from as well, okay? So impact and resistance training. Impact includes jumping, skipping, jumping jacks, elements of HIIT, and 30-second sprint. Not a very long sprint, okay? A 30-second sprint. So what you can do if you felt like today you couldn't jump, right? Okay? We sat down and we did hill thumping, isn't it? Right? You can start with that. As you retrain yourself, okay? You can start with that. Then as you get better, you can jump off your lower step, right? And then you keep on increasing, right? And getting better. Resistance training, build muscle and strength and prevent sarcopenia. You're supposed to strengthen all the muscles below your belly button, okay? Right? Strengthen below the belly buttons, and because these are mobility strongholds. If your leg muscles are strong, you'll be mobile. They'll be able to carry your weight, right? They are metabolic powerhouses, right? You know the muscles in your legs can reverse, right? Insulin resistance. We know that, right? They are your balance supports. These are the muscles, if you strengthen, right? You will be able to prevent yourself from falling down, right? You'll be able to regain balance, and that was what the balance was about. Okay, this was about. Okay, joint health and mobility. Retrain yourself. Okay, when we went down on a squat, how many of us could sit flat-footed? How many of us could do flat-footed squat? Means your feet are down like this, not on your heels. Not on your toes. You could sit like this with your feet down. Right, let's start retraining ourselves. We used to use Eastern toilets. Western toilets have made us lazy. Okay? If your joint is mobile, okay, if your joint is mobile, you'll be able to regain balance. Even if you're about to fall, right? You'll be able to regain balance. But if you have a stiff joint that is not doing the range of movement it is supposed to do, then how will you be able to balance yourself? You'll just topple over. Okay? Right? So we need everything. Okay? For bone health. We need the muscle, we need the tendon, we need the fat, we need the bone, we need the ligament. And I told you, I promise you, I'll tell you where the fat comes from. Where the person with a higher BMI has better bone weight. It's because a person with a higher bone weight has more stress on their bones, isn't it? Right? So the bone is constantly building itself. Sawa. So it's the only place where we healthier, I'm not fat shaming, I'm saying healthier is better. Okay, number 4, dietary changes. Optimize dietary calcium. Okay, dietary calcium. Dietary calcium optimization has a better positive effect on BMD. Okay. Calcium, what is the recommended intake per day? What is the recommended intake per day? Anybody? Huh? 1,200 is the recommended, right? Of which dietary is better. So as much dietary you can have in better. So for somebody like me, I don't tolerate milk. I don't tolerate lactose, right? And then where we eat or when we are moving about over a day, so sometimes there's nothing, right? So those days I just go home and pop a calcium tablet. But if you know such people or where you have to give you supplement maybe somebody and advise them dietary calcium, okay? Oh, sorry, this didn't come. So I added calcium-rich, a picture of calcium-rich foods. What are calcium-rich foods? Daily, I said, right? Tofu. Huh? Mabuyu is calcium-rich, yes. Sesame seeds, nuts, green vegetables, kale, okay? Oranges, vitamin D. What is the daily dose? Recommended dose? Sasa hapa inakuja swala ya sunscreens. Kwanza we are fully covered. Then sunscreen. Then we are not getting a lot of time outside. So vitamin D almost becomes a daily thing. It has a huge role in everything, isn't it? Right? Daily dose, 400 to 600 IU, okay? And 60,000 per week, okay? When somebody is really, really deficient, better for them to get a daily dose or get an injectable, okay? Then protein power. How are you going to build any tissue without the substrate? We know the substrate is protein, isn't it? Right? So protein should be 1 gram protein per pound of ideal body weight. And I like to do this in my clinic, right? I ask a patient what they have eaten for breakfast. And even, by the way, even in our public facilities, half of them will tell you mahamri, another half will tell you viazi karai, then some chapo, right? And some mkate, right? So I tell them, instead of buying this, why don't you buy 2 eggs and boil them and have them? Right? It's basic. I even use that with my antenatal patients. Basic logic, right? And how much is a mahamri going for? 10. And an egg, a raw egg is 20, so it's 2 times, right? But then it's going to make you less hungrier, so you're not going to go looking out for another chapo at lunch, right? And it's going to give you nutrition, isn't it? Right? So balance training, very, very important. Balance training is what is going to save you. It is what is going to save you from falls, right? You trip over, but you know how to balance yourself, because the body is a passive learner all through, right? You are balancing yourself, you'll be able to regain your balance. But you trip over, you can't stand on one leg, you can't balance yourself, your joint mobility is kaput, you're going to go down straight, okay? So balance training is very important. There's a lot on the net about it. But you can start by, when you're brushing your teeth, right? Hold one leg down and put one leg like this, right? And continue brushing, right? When you're doing your lock activities, don't do it in theater. Will cause accident. Okay? And then the last one, control chronic inflammation. Okay? So cut down on alcohol and smoking. Both are known to have a negative impact on bone density. Extremes of diet. Like, we do this all the time. Fried stuff every day, extremely sweet, sugary stuff, processed food. Let's try to cut down as much as we can. Right? These things are embedded in our diet. Let's go back to those times when we were not eating fried stuff every day. Okay? And then chronic inflammation, stress, and then endocrine related. So this is what I'll finish with. Do you want to look like this, or do you want to look like this when you're 70?
Thank you very much, Dr. Hafsa. I think watu wakitoka hapa wanapitia gym to get memberships. People will start Pilates and yoga. Wataanza diet, and then in a few days wataacha. But let's make a commitment to listen to what she said. So thank you very much. Let's appreciate her again. I think that was a very, very nice talk. We don't talk much about the issues of menopause. And This concludes our presentations for today. I hope you've all had a nice day. You've benefited from all the talks. And right now, I would like to call upon the speakers to come on stage, please, so that we do the Q&A session. After the Q&A session, our colleague, Dr. Mariam Wajumla, will come up and give the vote of thanks and ask a few questions as well. So if I could call on the speakers, please, to come on stage. You may want to remain standing, balance yourself throughout the Q&A session. Cameras off, please. Sorry. And no photos. All right. Any questions?
علمتنا رب علمنا الذي ينفعنا رب فقهنا وفقه أهلنا وقرابات لنا في ديننا